knee pain and arthritis. The cartilage of the knee is complex and is made of elastic compressive structure. The normal articular cartilage is called hyaline cartilage. It provides a smooth gliding surface to help in the motion of the joint. There is about 2 cc of synovial fluid inside the knee that helps in the motion and lubrication of the joint. Between the hyaline cartilage, which is called the articular cartilage, you can see the meniscus, the lateral meniscus, and the medial meniscus. The meniscus is a shock-absorbing cartilage. It's a cushion between the articular cartilage. The hyaline cartilage has 4 layers: the superficial, the middle, the deep, the calcified. After the calcified layer, you'll find the bone. These cartilage cells live forever. Good cartilage cells are sterile. They cannot make more cartilage if these cartilage cells are destroyed. If the cartilage is subjected to excessive wear, excessive trauma or injury, overuse, excessive weight, or improper alignment, the cartilage will wear away, leaving bone to rub against bone. The cartilage does not have the ability to heal itself by hyaline cartilage, but it can sometimes heal itself by inferior type of cartilage called fibrocartilage, especially if the area that needs to be repaired is small. So what is the treatment of arthritis of the knee? There are a number of treatment options that may help the patient. So the first thing the doctor will choose is a medication. People respond differently to medication. The doctor usually selects the type and the dosage and duration of the treatment. The medication got to be safe and effective. Ask the doctor a question about the side effect of this medication. There are several medications. One of them is the non-steroidal anti-inflammatory drugs. Let's just take Motrin, for example. The selection of this medication will be based on the physician preference and the patient susceptibility. The duration will be based on the effectiveness, the side effect of the medication, and the medical history of the patient. This medication can have side effects. The physician will ask the patient if the patient have gastritis or stomach problem, if he had renal failure or renal issues. Sometimes this medication also interfere with fracture healing. COX-2 inhibitors such as Cerebrex and Mobec can cause less GI side effects, but it can cause other side effects. Another medication that's recommended is Trimidol, Ultram. It's used for symptomatic osteoarthritis. Another medication is acetaminophen, Tylenol. Some people prefer Trimidol and Tylenol. Do you think it's more effective than Trimidol alone? This medication treatment is a core treatment. It's very important and recommended. The second issue is losing weight. You got to have weight loss. The normal BMI is between 18.5 to 24.9. The overweight between 25 to 29.9. The obese is 30 BMI or more. So it is recommended to do diet and exercises and lose about 5% of the body weight, especially if you are above 25 BMI. So we're going to give the patient nutritional consult. How about the metabolic syndrome? How we deal with that? These patients will have central, which is abdominal obesity, and you will have high blood pressure. You will have elevated fasting glucose level and dyslipidemia. These patients have the metabolic syndrome and they are complex patients. And the orthopedic surgeon will need support from multiple medical consultants. Then the third core item is physiotherapy, low impact physiotherapy. A low impact activity like swimming or cycling is usually better and it will add less stress on the knees. While jogging and running and tennis is a high impact activity, it will put more stress on your knees. You will decrease activity that aggravate the condition. Lifestyle modification to protect the knee with slowing the progress of arthritis. There is strong evidence that physiotherapy helps the patient. The physiotherapy will decrease the pain, will improve the function, increase the strength, the range of motion, and flexibility of the knee. Physiotherapy should be individualized with a program that needs the patient needs, the lifestyle, and their expectation. So the patient will do aerobic exercises, education, wellness, home program, and the patient should continue to do the therapy even if they feel better, because the benefit can be lost if the patient stopped the exercises. There are a number of treatment options that may help the patient. The initial treatment is usually non-surgical. The physician will also use intra-articular injection of steroids, viscosupplementation, or hyaluronic acid. It will relieve the patient pain and disability. Steroid injection, you can give about 3 to 4 injections per year. The relief is usually temporary. The viscosupplementation will improve the quality of the joint fluid. The problem with hyaluronic acid and viscosupplementation is the studies that are published did not meet the minimum clinically important improvement threshold. There is clearly a group of patients that this injection can help them, but the industry is more interested in competing against each other rather than finding which group of patients that will get benefit from this hyaluronic acid or viscosupplementation injection. Other methods of injection can be gene therapy or PRP or growth factors or stem cells. It's logical to pursue the efficacy of stem cells in cartilage regeneration. More clinical trials and more research is needed in this area. There are other treatment options. However, this treatment option did not show a clinical effective response. So the evidence is inconclusive. One of them is acupuncture, massage, glucosamine and chondroitin sulfate, valgus directing brace, wedges in the foot, or arthroscopy and lavage. Assistant devices such as a cane, shock-absorbing shoes, shoe inserts, knee sleeves, or support brace can help. Arthroscopy should not be done in arthritis unless there is a loose body or meniscal tear causing mechanical symptoms of recurrent locking, catching, swelling, and pain. There are some guidelines which are very good from the American Academy of Orthopedic Surgeons. These guidelines are suggestions, and the treatment of the patient with arthritis should be individualized, and that will be based on the doctor clinical judgment, the patient clinical situation and benefit, and the evidence tested and published. It's really a combination of all of these factors. If it works for you, it may not work for your neighbor. So basically, arthritis can be minimal, and anything can help the arthritis in this situation. It's like a roof have a leak. You patch it and the leak will stop. But if the arthritis is moderate, the physician has many options of treatment, and none of these options are predictable in the result. So if you have a big leak in the ceiling, you may patch it, but it may not work. But when the arthritis is severe, total knee is the most predictable option for treatment of severe arthritis. You got to reduce the pain and improve the function of the knee. And when the roof of the house is totally destroyed, you got to change the roof. The same here in the knee. In the cartilage of the knee, the water will increase early, the collagen is disorganized, the proteoglycan concentration and synthesis is decreased, the modulus of elasticity of the cartilage is reduced. Then you got to change the knee by a knee replacement. The doctor will remove all the damaged cartilage and bone and insert a new knee. There is some potential risk and complication with every surgery. There is no cure for arthritis. Injection may help, but it's only temporary. I hope this lecture was helpful. Thank you very much. This video is for educational purposes only. Please consult your doctor before you make any decision about your medical care.